Like that when one as a Muslim you. What a fantastic facility and initiative here at the St Vincent Pallotti Life Healthcare. First and foremost, I want to know from you, how did you become a psychiatrist? Because you come from a generation, clearly you're not a millennial.
No, clearly not.
And you come from a generation which I can only imagine the kind of stigma that was attached to the time when you had prior to you doing psychiatry, specializing, and also when you had specialized. Yeah.
Okay, so it's a bit interesting. Maybe I should say I'm the accidental psychiatrist.
Oh, okay.
Because I didn't set out to be a psychiatrist.
Right.
It happened, I guess, by chance, if you want to call it that. So I and my wife had both qualified. We were both in the same med school class. We then decided to go overseas to sort of just work, locum, see the world a bit. And because we were newly married, we asked the locum agency to get us a job in the same hospital. And typically we didn't know anything about going to the UK, so everybody says, go to London. So we said, go to London. And the agency said, well, sorry, you can't get you a job in the same hospital in London, but there is this hospital in Worcester, which they say it's in the countryside, but they can offer you a job, both of you. But happens to be a psychiatry hospital. I thought, oh my God, psychiatry. But anyway, because we were desperate and we wanted to go overseas, we said, fine, we'll agree. And I thought, okay, we'll just do it for 6 months and find something else. And then got to Worcester, started doing psychiatry, and I think contrary to what I saw in my medical school training, and when I did psychiatry as a medical student, was 2 weeks. We had a few lectures, maybe 2 or 3 patients, and that was my sum total of psychiatry knowledge for my medical school training. And I went on to Falkenberg, and as you said, this sort of
that's during your training, of
course. So you have the stereotypical view of people behind bars and people sort of walking around.
Very negative.
Very negative, absolutely. And that was sort of my concept of psychiatry, hence my sort of apprehension about going to work in Worcester in a psychiatric facility. But when I got there, it was very different. Partly because I guess we were in a first world country, but also the range of patients we were seeing was different. And having spent at least 6 months instead of 2 weeks, 6 months actually working in a facility, getting to know patients, gave me a really different perspective on psychiatry. I thought, oh, this looks interesting, so let me try it a little bit longer. And then the consultant I worked with, she said, oh, well, why don't you maybe sort of just join the rotation? You are here. Continue and then maybe sort of think about exams. I thought, oh, okay, give it a try. I'm here, got nothing to lose. So I sort of just kind of stumbled on like that. And
let's call it qadr.
Maybe, yeah, that's probably a better way of putting it. Qadr, because like I said, I didn't really set out.
Correct.
In my mind, in fact, I wanted to be an anaesthetist. Very far removed from Pallotti today.
But I think being in Cape Town, well, you're from Cape Town?
Absolutely, yeah.
Being in Cape Town in South Africa, where we sweep things under the rug, the chances of you becoming a psychiatrist would be less in South Africa.
Absolutely. I don't think I would have actually been a psychiatrist at this stage.
Yes. So you being in Worcester really in the UK opened your mind, your worldview, of course, but then specifically your specialization started there.
Yes, my exposure to psychiatry, and then my training into psychiatry, and then after that, I started to take the training more seriously, and I moved to the Oxford rotation, so I did some training there, and then moved up to Birmingham. And Birmingham was interesting. I don't know if you know much about the UK. Birmingham is a very cosmopolitan society, and about half the population is non-white. Very large Muslim, Pakistani, Indian community in Birmingham.
You'll be excused to think that you are in India or Pakistan.
Absolutely. So again, I spent about 9 years there, and so that's sort of the latter part of my training. And there, then I'm sort of starting to integrate. Okay, now you've got kind of the Western psychiatry model that you've learned, but also many of my patients are Muslim. So now you have to start having this conversation about how does Islam fit in with Western psychiatry. Whereas that wasn't really a big problem in Worcester, because Worcester is largely sort of a white population, secular, non-Muslim population. So then sort of I started really looking around, and also getting involved in some of the Muslim communities, and then trying to integrate the Western concept of psychiatry and the Islamic concept of psychiatry, and doing a little sort of reading around, and realized actually it's not too different. You know, when we think about therapy in the Islamic way and we look at what we consider to be Western therapy, there's huge overlaps. And even when you start to look at some of the lives of the Sahabas, it's very interesting. You know, when you go into it and you look at it, many of them had what we would call anxiety and depression. You know, they didn't call it that, but they got distressed, they got upset, they got...
I think it was a time of the Prophet's Seerah, Sallallahu Alaihi Wasallam, Am al-Huzn, the year of sadness, or yeah.
Well, not only that, interesting, if you look at Bukhari,
Yes.
there's a narration of the Prophet ﷺ actually had suicidal thoughts. Right? So this is the period where, just after the first revelation, and there's a long period where he doesn't receive revelation. And you know, this is after the first revelation, he thought something had happened to him, that he was possessed, and you know, his wife comforts him. So we know all of that story. But the bit in Bukhari I find interesting is that he goes up to the mountain and sort of attempts to throw himself off, and every time Jibreel would appear to him,
every time comes and saves him.
Saves him, yeah. But to me, what I take away from that, and I think, you know, this is sort of maybe where our culture comes in. So, well, it can't possibly, the Prophet never had that. And to me, it's like, okay, the Prophet had physical illnesses, we know that. You know, he became physically unwell at time, he had pain. And what he also says...
He was affected by magic.
He was affected by magic. But also what he says, very interesting, is that, you know, if I have a fever, then my fever or my illness is like many times more than the effect that you would have.
Wow.
So if you then apply that same rule, so okay, if he was emotionally distressed, his emotional distress must also be more than what the average Muslim would go through, what the average person would go through. So then one thinks, well, actually it's probably not surprising. Maybe he got to that point where he felt so distressed, you know, so unwell. And remember, this is also kind of what I would consider pre-Islamic.
I think I'm getting so excited here. And
we shouldn't talk about medication in isolation. It's part of a package of care. So often when I talk to my patients, I say, okay, yes, even if I prescribe you medication, it's only one component, one aspect of your care. Right? And you know, me as a psychiatrist, I often say that consider me like the conductor of the orchestra. Right? So for your illness, there may be different components that we need to put together to help you. So you might need to see a psychologist, you might need to, for example, see a social worker, or you might need to go see a financial advisor about your financial problems, or we're going to refer you to somebody for your marital therapy. Yes, somebody prescribe you medication as well to help your symptoms.
That's a very interesting analogy, to see a psychiatrist as a conductor. Okay.
Yeah, because essentially, you know, somebody comes to me and I do an assessment, and my assessment is holistic. So I need to look at the psychological, but I also need to look at the physical, because I'm also a doctor. And as I said to you, the interaction between medicine and or medical problems
and other extenuating factors.
Exactly. I have to also put a social worker hat on and say, actually, you know, is it your problem at work that's maybe causing you this stress? So maybe we need to talk about work about it. Or do you have a housing crisis, or do you have a financial problem? Okay, let's see if we can resolve that. So it's about looking at different aspects of that patient's life and trying to see where can we intervene. So intervention is not only medical. Intervention can be multiple factors: psychological, social, financial, various other ones, even spiritual. You know? So social aspects, and then there's the spiritual aspect. Because often when patients are very distressed, you know, they find that they also struggle in terms of their spirituality. Or, again, commonly in our community, you know, I get this thing, oh, you have depression, you know, there's something wrong with you.
You're lacking of your spirituality.
Yeah. So often they get told that, you know, and they come to me very distressed, and I said, no, it's got nothing to do with your lack of iman. Okay? Because then I might as well accuse someone who's got diabetes and hypertension, sorry, you've got bad iman because you've got diabetes. You know, it's the same thing. So I think, unfortunately, there's a lot of misperception also perpetuated out there, and it's also trying to rectify. So actually, no, the spiritual aspect is just as important, you know, as your physical and your psychological, and they all need to be taken care of. So it's about getting the balance right. Yeah. So me as the conductor, if you think about a conductor, what does a conductor have to do? He kind of has to get the balance right in the orchestra, make sure that everything is in tune. That's really how I see my role.
Dr. Imthiaz, thank you very much. It's been enlightening.
Shukran.